Hello and welcome to my channel. I am Dr. M.D.Zafar and I'm going to continue my lectures on the trauma series. Today the topic is pneumothorax. Pneumothorax patient can present in the OPD or trauma with tachypnea, tachycardia and decreased oxygen saturation. So very first thing is that we should know what are the different types of pneumothorax. I have classified them into four: spontaneous, iatrogenic, traumatic, and tension pneumothorax. Spontaneous is further classified as primary and secondary. In primary spontaneous pneumothorax, there will be no underlying disease. However, if there is any underlying disease like COPD, tuberculosis, malignancy, in that case, it will be secondary. Similarly, if during any surgical procedure pneumothorax happen, it will be named as iatrogenic. It can occur when passing a CVP line, taking a pleural biopsy, performing pleural tap, or an ICU patient who is on positive pressure ventilation, they are at a high risk. So this is the very important point because it is usually tested in the MCQs that there is an patient who is in ICU and you have been called because the patient is having tachypnea and there is decrease in the saturation. So in that scenario, you should quickly think about pneumothorax and you should know that whenever you're having a scenario, what should be the management. We will talk about that in detail. And in case of bronchoscopy, it can also happen, but in that case, it will be a delayed presentation. Similarly, traumatic or open pneumothorax can be because of any penetrating injury, which could be due to knife, gunshot, or it can also occur secondary to a blunt trauma that can result into the fracture, resulting into pleural injury. Now, the important thing to understand is that all of these types have the capacity to turn into tension pneumothorax. So, tension pneumothorax is not a type but a sequelae of all these different subdivisions of pneumothorax. What happens is that in tension pneumothorax, air enters during inspiration but cannot escape. So the air will keep on increasing in the pleural cavity and eventually the lung on the affected side will collapse and it will cause a tracheal shift. And there is another point that tension pneumothorax is one of the most severe types of pneumothorax. So now we will talk about primary and secondary pneumothorax. Primary pneumothorax is likely to occur in tall, young males without any pre-existing pulmonary disease. They can develop subpleural blebs, which will be less than 1 to 2 centimeter, or it can be secondary to bulla rupture if there are more than 2 centimeter. Now, air will enter the pleural space and it will try to compress the lungs. It is more common in tall males who are smokers. And secondarily, Marfan syndrome patients are likely to develop primary pneumothorax. In case of secondary pneumothorax, COPD, tuberculosis, pneumonia, malignancy, or cystic fibrosis or any other pathology will be there. An important thing is that because of the three existing disease, the pneumothorax will be more severe and it will require more aggressive management. So what will be the presentation? There will be ipsilateral chest pain with shortness of breath. The severity of the symptoms will depend upon the amount of air that has collected in the pneumothorax. The patient can present with tachypnea, tachycardia, decrease in the oxygen saturation, and the collapsed lung will receive blood, but it will not be oxygenated. So there will be hypoxemia, and it can be asked that it will be a zone 3 VQ mismatch type of scenario. Now, bigger the pneumothorax, more will be the hypoxia. Now we will talk about the presentation and the type of investigations which are required. We will talk about the clinical scenario in terms of the 4 steps of examination, that is inspection, palpation, percussion and auscultation. In a clinical scenario where you're suspecting the patient to have pneumothorax, first of all, on palpation, there could be surgical emphysema present in the chest or neck. On inspection, there will be decreased expansion or movement of the chest on the affected side. On palpation, there will be decreased chest expansion both by the manual method and also if you try to measure that in the comb inches, it will be reduced on the affected side. Then we have percussion. In pneumothorax, there will be hyper resonance. At the auscultation, you will have decreased breath sounds on the affected side. In terms of investigations, chest X-ray is the most initial and very important investigation. However, the most accurate test is the CT scan. The most sensitive test is the lateral decubitus chest X-ray, and it is able to detect around 5 cm of air. Now, in terms of the management, it depends upon the site and the type. First of all, we will start the patient with supplemental oxygen. In case of primary pneumothorax, if the labs ruptured are less than or around 2 to 3 cm, or in case of secondary pneumothorax, the size of the perforation is between 1 to 2 cm and the patient is having minimum symptoms, they will be managed conservatively. But if the patient is symptomatic, then we will have three options. Either go with a needle decompression, chest tube, or video assisted thoracostomy, otherwise known as VATS procedure. Now, needle decompression is usually done in the second intercostal space in the mid-clavicular line, and it is done initially in the trauma room where the patient arrives with a suspicion of severe pneumothorax. This is not only for relieving of the symptom, but it also confirms the diagnosis. This is followed by the chest tube intubation, which is done in the fifth intercostal space, mid or anterior axillary line. In terms of the VATS, what is important is that there are certain indications in those patients who will directly go with the VATS, such as there are high-risk patients who are mountain climbers or they have aircraft pilots. If there are large blebs on CT scan, if there is bilateral pneumothorax, if there is previous lobectomy, recurrent pneumothorax, or a non-expanding chest despite placement of chest tube, or very importantly, if there is a persistent air leak for more than 7 days. So if any of this scenario is present, we will directly move with the VATS. In case of chest tube, if there is a large pneumothorax, if the needle aspiration has failed, or there is a traumatic pneumothorax, then we will go with a chest tube initially. Important step is that post-intubation X-ray is used to identify the correct placement of the chest tube. Apart from this, pleural disease is a procedure which can also be used. In this, either chemical or mechanical support is used for patients with recurrent pneumothorax. In case of chemicals like TALF or aminocycline, they are used, and the pleural surfaces are irritated to form adhesions of scar to close the opening that has resulted previously into pneumothorax. So now we will talk about the tension pneumothorax. In tension pneumothorax, there is a triad which will be tachycardia, hypotension, and raised JVT. These 3 points are going to be found in the case of or scenario of tension pneumothorax. As I have explained in the shock lecture that tension pneumothorax along with cardiac tamponade are few examples of the obstructive type of shock. So what is the pathophysiology behind the tension pneumothorax? Air accumulates in the pleural space, but it cannot escape. So as a result, it will keep on building up and it will increase in the intrathoracic pressure. So increase in the intrathoracic pressure will cause lungs to collapse, and as a result, there will be variceral shift. Eventually, the pressures will increase that the pleural pressure will become way more than the venous pressure, and it will impair the venous return, and it will result into obstructive shock. Signs and symptoms are going to be similar to the spontaneous pneumothorax, but they are more severe and they require more rapid management. Examination findings are also similar, but in addition, there will be raised JVP, tracheal shift away, and hemodynamic instability. In case of the tension pneumothorax, X-ray is not required. Tension pneumothorax is a clinical diagnosis, and the books say that X-ray should not be awaited, but instead the treatment should be started. We have two treatment options: decompression by the needle, that is in the second intercostal space in the midclavicular line, followed by definitive management, that is chest tube, which is done in the fifth intercostal space in the anterior or mid-axillary line. But according to the latest ATLS guidelines, it is stated that the needle decompression and chest tube should both be passed in the fifth intercostal space in the mid or anterior axillary line. So next we have the open pneumothorax. Open pneumothorax happens when there is a penetrating chest trauma and it creates an open wound and air is sucked into the pleural cavity, resulting into a increase in the intrathoracic pressure. So this will act as a one-way valve. Due to the negative intrathoracic pressure, the air will keep on entering and it will expand the pleural cavity, but the lungs will be collapsed. So what happens is the management for open pneumothorax is to apply occlusive dressing with three sides sealed, and we will keep one side open. Now this is followed by chest tube insertion at a side which is distal to that wound which has resulted into the pneumothorax. A chest wound of more than 3 cm is likely to cause open pneumothorax. Number 2, if the chest wound exceeds 2/3 of the diameter of the trachea, then it is likely to produce open pneumothorax. So this was all about pneumothorax, what are the different types, their clinical presentation, and their management. So thank you very much for listening.